A common question that we receive is regarding the size of the abdominal aortic aneurysm and how we come to a decision of how to treat abdominal aortic aneurysms. Generally, we adhere to national standards, which suggest that we should treat asymptomatic abdominal aortic aneurysms after they reach a size of 5.5 centimeters. In some patients who have small native arteries, that threshold may be reduced to 5 centimeters, such as women. For symptomatic aneurysms, those aneurysms which are tender or those aneurysms which are ruptured, obviously we treat those aneurysms in a emergent or semi-urgent fashion. But for asymptomatic aneurysms, 5.5 centimeters seems to be the prudent threshold. Some people ask, well, if I have an aneurysm, why not treat it as soon as it's identified? And the rationale is through the UK small aneurysm trial and some other very well-performed broad population studies, we know that many patients, approximately 25% of patients, will not reach a threshold to undergo repair. And unfortunately, in a population of patients that suffer disproportionately from cardiovascular disease and oncologic, i.e. cancer problems, other issues will become more prominent and clinically significant before the aneurysm reaches a threshold for repair. And so for that reason, 5.5 centimeters is generally the threshold for repairing the aneurysm. Generally, when you're seen in the office, we may obtain pulmonary function tests. We may ask you to have a cardiac nuclear medicine stress test to determine if you require cardiac catheterization. The three systems that are germane to the perioperative mortality and morbidity around abdominal aortic aneurysm repair include the renal function for a patient, the pulmonary function, and the cardiac function. And therefore, we evaluate those systems closely, which gives us an idea of what the perioperative risks are for repairing an aneurysm. And in general, I tell patients that we are weighing the risk of your abdominal aortic aneurysm causing you a problem where when that aneurysm reaches approximately 5.5 centimeters, the risk is essentially a 5% risk of rupture annually if it stays at 5.5 centimeters, or as it grows, that risk of rupture is actually going to increase annually. But for a 5.5 centimeter aneurysm, the risk of rupture is approximately 5% per year. And we like our perioperative mortality to be less than 1% for abdominal aortic aneurysms and approximately 2 to 3% for open abdominal aortic aneurysm. And so one can see that we have the rupture risk of 5%, the risk of repair as approximately 2 to 3% for an open repair. And in our most recent year of analysis for 1 year of open aneurysm repair, we had no mortality. Over the last 24 months, we've had no mortality for the repair of juxtarenal or infrarenal abdominal aortic aneurysm repair performed in an open fashion. But once someone has increased cardiac issues, all of a sudden the risk of these surgeries start to creep up, or a patient with renal insufficiency or pulmonary disease from long-standing smoking combined with cardiac disease, all of a sudden you may get risk for the surgery up here and risk for the patient rupture at this level. And so when the risk of the surgery exceed the risk of the aneurysm rupturing, then obviously that's not a procedure that should be done. That risk-benefit profile is not favorable for the patient. And so that's why we look to mitigate those risks by optimizing cardiac function, whether that patient needs a cardiac catheterization with an intervention. Maybe pulmonary rehabilitation will reduce their pulmonary risk, optimization of renal function, and approaches to mitigate the risk of their renal dysfunction. In terms of repair, in general, if one looks at this model, this is the typical endovascular repair, which is an endovascular device placed below the renal with the device fixated to the aortic neck below the level of the renal arteries. In some cases, we now have newer investigational devices and commercial devices that allow us to place this device up above the level of the renals and that have fenestrations or holes on this device that allow the renal arteries to be preserved and stented. But this is what a typical infrarenal bifurcated device looks like that may be placed for an endovascular repair. Post-operatively, for an endovascular repair, we typically expect that patients will be leaving the hospital within 24 to 48 hours, and the real benefit of the endovascular repair is that early ambulation, quicker return to resume normal activities of life, and an early discharge from the hospital. So those are some of the early considerations and the perioperative considerations that we have regarding the treatment of abdominal aortic aneurysm, how we come to that decisional process.